I don't know, some 120 articles, ma'am? Something like a huge number of articles. I mean, she's a great authority. And I think once we finish this session, we'll go on to ma'am's medical legal session. I think what she's done is she has collected the questions we had sent. She will present them. And followed by that, we can actually have the question answer session. So starting off with catching them young, okay, we have Vijay Anand. Vijay is actually a pain specialist. He's working in Apollo. No, this is called not Apollo. He used to work in Apollo before. But he's what is that? Axon Group. Yeah. And they've done a lot of work on pain. He's trained in UK, in Australia, I don't know where else. He's done a good, and he also runs a pain school for youngsters, and that's what he's going to talk about. That's what catching up about is. Anurag is working as a consultant in GVS, GSVM Medical College, and he's like he said yesterday. He's given his introduction. His only what do you call the area of interest is pain. So here we go. Thank you, guys.
Cheers, Sue. Welcome back, and a very good morning. Good morning to the chairperson as well. Now we've talked about high-tech to low-tech. I'm going to talk about extremely low-tech over the next 10-15 minutes. We talked about cities, we talked about towns. I'm going to talk about villages and what we do in the villages over the next sort of 10-15 minutes. Now, medicine is a calling, is what I understand, and medicine is a challenge as well. The challenge is particularly tough if you were me, because on the first day in medical school, you're asked to write a love letter, right, as part of ragging. And that love letter is to my anatomy professor, right? And it becomes even more challenging if the professor's son is your good friend and your schoolmate. Right, I'm talking about love letters because it's kind of completely unrelated, you might think. But the thing is, I don't know if any of you have written love letters. I mean, these days no one writes. It's just SMS and emails, isn't it? I mean, people of a certain vintage actually know that. And you know that the girl is not interested in your calligraphy, how well you write the love letter. She's interested in the words and the emotions. And that's exactly what I'm trying to capture here, because this project which we're running is our own love letter in terms of our emotions and the toil, what goes into it. So this is the whole thing. And I have to thank Shiv, because I went to see him in Chennai with a very ulterior motive, actually, to see if we can squeeze some money out of him for a project. He kind of kept away very, very cleverly. But anyway, and thanks for inviting me, and also thanks for helping me to reflect, because every time we give hundreds of lectures as a group, it's an NGO, what we run, it's called the Traveling Pain School, but no one ever asked us to say, talk about what you're doing, because we go and talk about what they have to be doing, right, the undergraduates, what we do. So this is what it is. Now, the thing is, what is the needs of our country is the biggest question. And this is the information we have. So I'm going to focus on the rural side of things, actually, because this is where most of our resources have to be pulled in. And this is the report which came out last year, and this was looking at three main issues: accessibility, availability, and affordability of consultations, of medical treatment, of diagnostic facilities. So if you look at the graphs, it's quite apparent that the rural people haven't got much to go with, because they have to travel more than 5 kilometers just to see a doctor. Now, if you look at breakdown into government and the private, it's not much different, actually, because this is where the problem is, because this is the diagnostic facilities, what we're looking at. I just want to quickly go through the needs. And if you ask them what actually drives them to the private sector, and this is what they come up with, to get quickly attended to, the doctor availability in the private sector and less waiting than the government hospitals. And this is the reason why they go to the private sector hospitals to get treatment as well as the diagnostic facilities. Now, if you look at the spend, the affordability, it's quite damning, actually, because the out-of-pocket expenses is extremely high. If you look at it as a part of their salary, a monthly salary, see, there's a lot of changes there. At least 60% of the expenses in the private sector, particularly, goes through the diagnostics and the treatment. And if you look at the source of payment, again, I mean, we talk about insurance and how India is developing into a superpower. It is not, because we don't have insurance. At least 70% of patients in our country do not have insurance. I mean, there are a lot of states where they have the government insurance. The Tamil Nadu government has it. The Telangana and Andhra Pradesh government has it, and a lot of other places have it. But still, there's more than half the country doesn't have the insurance to pay for. And this is the damning statistics which we have. So if you look at, this is the concern areas, particularly in the rural, if they are poor, you're damned. You don't have availability, you don't have equality, you don't have affordability. Now, the reason I'm presenting the statistics is this is the rural population which the government, in its kind of epiphany, want the undergrads to go and serve, right? These are the least trained doctors sent out into the community to deal with the most complex of pain problems. Now, how stupid it could be. I mean, the thing is, there's a lot of argument, and there's a push from the societies to actually have the postgraduates to do it rather than the undergraduates. Because if you want to provide quality service in the rural areas, then you want trained doctors to do it, not novices. Okay, so this is the issue, because people have to go into the rural service one day or the other, because there's a big buzz around it, and there is no escape, unfortunately. Now, if you look at the needs, there was a recent paper in Nature, this was published yesterday, looking at disability in different populations. Now, depression comes to the top, okay, in terms of lost manpower, in terms of economic damage to the country. But if you look at the second biggest cause, it is pain. It is neck pain and back pain, which is the largest cause of disability. And these are manual workers who have pain. I mean, we have some data, Indian data, in terms of prevalence of pain is about 20% in the metros, and we don't have data for the rural areas. I'm pretty sure it's much, much higher in the rural areas. It's just kind of, if it's not documented, it doesn't exist. I mean, seems to be the theme of this meeting, what we're having here. And the kids are sent into the rural areas to manage. Now, if you want to train these people to manage pain well, you just look at the scales. I mean, we were looking at healthcare graduates in general, and there are 45,000 medical students coming out every year from this country. Okay, and there are about 15,000 physiotherapists going out, and there are nearly sort of 70 to 80,000 nurses coming out of nursing school. So which you're looking at a 1 lakh plus population which needs to be educated on how to manage pain well. Now, we do not have any, the curriculum doesn't address any of these. We kind of looked at the AIMS curriculum, and there's a lot of talk about pain in different perspectives, but it's not put together. I mean, they talk about pain physiology, they talk about pain pharmacology, but when it comes to the final year, it's kind of clubbed along with orthopedics and neurology or something, and it's not actually given the right sort of prominence it deserves. And I mean, we run a lot of workshops for working anesthetists, and we find that at least 30 to 40% of anesthetic doctors in our country do not know how to differentiate between a nociceptive pain and neuropathic pain. And that's the reality. We have the data. So it needs to go into the population, and we need to sort of look at what could be done. So this is what we did. So we knew what the challenge was. We know the needs of the nation, of the country. So we thought, well, can we do something about it? When I say we, it is a group of, we call ourselves jobless doctors in Hyderabad. Okay, this is a friends, this is an NGO, it's a non-governmental organization. We just got together, some common shared ideology. So let's go and talk about this in the community. So that's what we done. And the thing is, yesterday evening, it was so heartwarming to listen to the juniors speak to all the people from overseas, trying to find out, why, how you can go, how you can practice, and how much you can earn. A lot of questions being discussed, a lot of doubts being sort of cleared. Mine was the other way around, actually, because I used to practice overseas, and I took the opposite route to come back to settle down in India. And one of the reasons is I thought, well, it'll be a big challenge to do what we want to do, and this is to bring about an awareness about our pain medicine, one of the reasons for me to come back. And you would think that coming back from overseas means the trajectory will be from privilege to power, but unfortunately it hasn't been. And part of the reason why what I want to talk is the kind of hardships what we go through when we try to do this teaching program. Now the program itself is is a very straightforward one for the undergraduates. It is actually run by the ANZCA, which is the Australian New Zealand College of Anaesthetists. And India, we were the first country outside Australia to actually bring it to India. They ran a lot of training programs for doctors in the rest of the world, but for the undergraduates, this is the first time it's coming out of Australia. And we have the trainers program, and we have a lot of collaborations going between them. And we've done a lot of work. We've kind of taught nearly 800 students over the past 6 months, and still there's a lot of things lined up because our ambitions and our what we want to do is completely different because we are looking at the bigger picture. About 40,000 students need to be taught, and these collaborations comes with hardships, is what I wanted to emphasize, because coming from private sector, pretty much everyone in the group, in the NGOs from the private sector, having a shared ideology to bring about a change in the society, to bring about a cultural change in the way medicine is practiced, it's a big challenge, and I think it's going to be a lifetime work for me to actually get there. But what it is there's always, we always look at the hardships and obstacles, and there's nothing wrong with it. It's just the way we deal with it, and we have found sort of ways and means to deal with it. Now, very often, pretty much every day you wake up and you'll get a phone call saying, well, that program which you arranged has been cancelled. And this kind of sucker punch we feel every day coming from the different sort of sources. And the thing is, you think your project is going fantastically well, and every week we end up in a cul-de-sac not knowing where to go, right? Because the kind of support which we need from the government sector is not there. Okay, this is the job which the government should be doing anyway, which we have taken up. And then every month, you look that your dreams are getting dashed, and then you kind of reconsider it and realize, well, you have to have a different sort of strategy about the whole thing. And on occasions, we have walked away from few projects. So it is a challenge, it's a huge challenge. And the thing is, we get our sort of moral sort of support from between talking to ourselves and keeping in touch with people outside the country as well to keep us going. Now, you would like to know what we have done so far. Now, in terms of economy of scale, it's kind of a reasonable thing. We've traveled not just in Andhra Pradesh, not just in Telangana. We've traveled across the country. So we have taught 1,500 doctors in the last year, and we have trained close to 1,000 undergrads. Now, when I call undergrads, it's the medical undergrads as well as the physiotherapy undergrads. And it is all done as workshops. It's a kind of brief 5-hour workshop where we go and teach them, and it's based on interactive lectures, brainstorming sessions, and then small group discussions. It's run typically along the lines of the BLS and the ALS, where you have 6 faculty for 50 students, and then for every faculty sits around 6 to 8 students, and then discuss about case scenarios and things like that. And the kids are fantastic. They're kind of looking to learn, and if you provide the material in a manner which they would love to pick it up. There's nothing like that. And then coming from outside and providing them the information, there is no sort of, big order attached to us. We are not their professors with the long coats. We're just kind of practicing pain physicians coming from the private sector. So they're quite sort of open about it. They interact, and then they feel how much they have missed in the training, because the emphasis is completely different. And everything is standardized. They get a manual, they get feedback forms, they have a pre-test, they have a post-test, and you get a certificate in the end, which is certified by ANZCA, which is the Australian New Zealand College of Anaesthetists. Now, if you look at the feedbacks, it's been overwhelmingly positive. And if you look at the knowledge gain, there's a 70% increase in knowledge by the end of 5 hours. And this is just amazing what we do. And we presented this data just last month in a World Congress, and people were amazed. And this program is actually going to go places. There's a medical school in US which is taking it up and looking at it in a big way to provide it. So that's the sort of the work we do. And our further thing is to in the next 5 to 7 years to get to at least 10,000 students every year on year. And for that, we need to run a lot of Train the Trainers workshop, which we're running anyway. So that Train the Trainers workshop is typically it's a 3-day affair where we go and talk to them about adult learning principles and things like that. How to teach, how to make the kids understand, how to make it interactive, and all those things come into play. And not only that, we have also been sort of recognized. We have recently been awarded the Royal Australasian College of Surgeons kind of scholarship for us to go and do the teaching. We've also been awarded the International Association of Study of Pain Developing Countries Education Grant. And the work we do gets regularly published in the IASP newsletter as well as the British Pain Society newsletter as well. So the recognitions and the awards come. But if you ask me whether it has given me any satisfaction, I would say no. because there's still a lot of things to do, a lot of work left to do, and I think it's a lifetime work what we're struggling to achieve in that sense. People. If someone in mundane job, you think, well, I'll take a few weeks off and go on a holiday, on a vacation. For us, the job is the vacation because we enjoy every minute of what we're doing. Because it's typically like this, we work Monday to Fridays, pack our bags on a Friday night, go away in a train or a bus or whatever it is. We've also took the boat on occasions to get to the place where we have to teach. And it's a fantastic experience, what we do. And if you think, if you ask me if you're richer for that, I would say, yes, I'm richer for experience. I'm rich for the fact that you have invited me to speak here about what we've been doing, and I'm sort of privileged and honored to be here. So I think it's kind of going through what we have to do, and got quite emotional this morning, actually, because as I said earlier in the talk, no one has ever asked to talk about the feelings and the emotions, what we go through, and the hardships, what we face. Now, the thing is, there is a saying attributed to Aristotle, where the needs of the world and your talents meet, therein lies your vocation. And I think we know what the needs of this world are. I think we have some talent to match it, and hopefully we have found a vocation. So I think with that I'll finish my talk. And before that, I just have one single plea or a plead. There might be senior colleagues sitting here in the audience who might have been in sort of positions of power and influence. And if you're able to help us in any way, I'm not talking about financial help at all, in terms of organizing things, we would be more than happy to come over as a group to do the teaching. As I go, just a couple of slides, and this is our website. You can see there are thousands of photographs of undergrads and the teaching, what we do, and this is my Twitter site, probably the largest in the world in terms of pain-related information. Pain-Free India it is called, and with that I'll finish my talk. Thank you.
Vijay, please have a seat. Sit down, be comfortable, Vijay. Next part of the talk is by Anurag. So it's moving from taking pain to the rural areas. Now, what is needed in the medical colleges? Now, that's a big challenge. Now, the government wasn't supporting Vijay, like nobody is. Now, here also, he's working in a government setup, and still government isn't supporting. How much he has to struggle to actually set up a pain work, isn't it? Yeah, so he's going to talk about that. Anurag, thank you.
Thank you. This is for the forward.
That's forward.
First, I would like to thank Dr. Shiv Kumar Singh, sir, to giving me this opportunity to present my views in front of this revolutionary group of anesthetists from all across the globe. And it is often being said during our MBBS period that never go for an interview or the exam after the topper of the class. So this is my situation as of now. And I must, before I begin my talk, should warn you that after the wonderful presentation by Dr. Vijay with the philanthropy ideas about the need of our society, my talk is going to be very mean and selfish. It is going to be related to the thing which I expect that our society of anesthesiologists should do for the pain medicine. Oh, sorry. So first I will start from the what is pain medicine. We usually think that managing the post-operative, peri-operative and labor analgesia is pain medicine. Answer is no, because this is the prerogative of the peri-operative physician, which is anesthetist. Is it acute pain management? Answer is again no, because acute pain management is being started from the nook of your galley by the chemist. You start taking up with a Vovron tablet and ends up with the super specialist. So then, pain medicine, also known as algology, the term given by the Dr. John F. Bonica, is management of chronic pain problems which are complex in nature to diagnose as well as to treat. And it requires a vast knowledge of all diagnostic possibilities as well as the treatment options available. Interventional pain management, which many of us are fascinated by, is a very small, hardly 5 to 10% part of the whole pain management thing. So just to peek into the history of modern pain medicine, though it has been there since the time of Socrates and Sushruta, but in the history of modern pain medicine, Dr. John F. Bonica is considered to be the father. He was an anesthetist. It has been propagated by many in India as well as in abroad. In India, to name a few, Dr. Bhatia was from BHU, and he was one of the 5-7 person who were standing besides Dr. John F. Bonica when he incepted the IASP, International Association for the Study of Pain. Unfortunately, in last 20 years, we have got many wonderful teachers, but still it is struggling to get its due recognition in our society. Many people have many views, especially from our friends and seniors working overseas. They consider all these outgrowths of our anesthesia as the subspecialties, including Dr. Shiv Kumar Singh. But in India, as we know that names do matter, I consider pain medicine as the super specialty of anesthesiology. And when I talk pain medicine, I am talking about the chronic pain medicine, including interventional pain management part. And I can very well safely say that why I am calling it super specialty, because if a cardiologist or a neurosurgeon is considered to be a super specialty of their parent branch, so should we. So why we are staking our claim over the pain medicine? So these are few things in which anesthesiologists have an edge over other specialties, like we have the natural skill to do the minimally invasive procedures related to spine, like the spinals, epidurals, and other interventions which we do for the regular anesthesia practice. Honesty, this is something which I firmly believe that it is the integral part of the anesthesia training. Till you are in anesthesia only, not doing critical care, not doing pain management, you are absolutely honest. Hardcore, maybe by default also. Because even the samples you get from the companies are of ketamine. What will you do with that? And second is the quest for learning. It is again there are only two branches in the medicine. One is radiology and one is the anesthesiology, where you have to read about the mistakes which can be done by the others. Not only about only your branch, you have to read about the other things also. So, but there are certain areas where we lack to become a pain specialist. Reluctance to the patient interaction is one of the major things. I get to interact with many residents of anesthesia in various conferences where they accept that we chose anesthesia sir because we didn't like to interact with the patient. कौन दिमाग खपाएगा मरीज के साथ में, बहुत अपन को मिलना ही नहीं. And it is यहाँ पे नहीं चल सकता ऐसा. You have to interact with your patient. You have to interact with the father, mother, sister, spouse, and distant relative of the patient while you are offering them any intervention or any procedure for this matter. Lack of skills. We do know how to do a wonderful PSC. Actually, many times we get to know and we inform the patient that you are suffering from the hypertension, diabetes, and other ailments. But still, we are very poor with our musculoskeletal examination, apart from seeing the spine, whether it is straight or not. So, but in chronic pain management, you need to know the musculoskeletal examination, as well as you need to know the neurology, orthopedic examination, as well as if you cannot read your own MRI, you cannot treat a patient. By the report of MRI, you cannot treat a patient, especially with the interventions. And the only investment, the first day we enter into the MD anesthesia or DA for that matter, we know it for sure that the only investment I will need throughout my life is a mobile phone and in a car or a scooter. But here it doesn't work like that. Here again, like any other clinical specialty, you have to spend a lot of money to start your own setup, or you have to compel your government or your employer to give you a lot of things when you can start. And one more thing, there is a kick start, always a kick start in the anesthesia. From the very first month when you start your practice in anesthesia and your surgery colleague starts his practice, on the 30th of that month, you are celebrating because you have earned 1.5 lakh rupees. And he has earned hardly his bread and butter. But there is no kick start. Months, for weeks, for maybe... you don't get to see any patient. You don't get patients who are ready for your specialized work. You don't get patients who are ready to believe you, because most of the time we are telling them the diagnosis which no one else has ever told them. Like you are suffering from the cervical facet syndrome. but he has never heard about this term. And poor marketing skills. We do not have. We are very habitual to work behind the curtain. So there are some specific needs of the pain medicine, which is first and foremost is the willingness to learn more and for a very long time. It is not like that you know how to poke a needle and you learn it in a weekend courses and you think that you become a chronic pain physician. No, it is not possible. Investment is required and ready to bear frustration, as I have talked earlier. And it is again very important, like in anesthesia, either spinal works or it doesn't work. Either the tube goes inside the trachea or it is outside the trachea. But here, all-in-one phenomena doesn't work. It is a clinical branch, you get the clinical relief only. In the initial period, you get the patient after your intervention and he says, oh, kuch doctor sahab, kuch farak nahi pada, and you get frustrated. But when you inquire, you come to know, like you treated her low back pain and now she is disturbed with her neck pain. And she was thinking because you poke a needle here, so the neck pain should also go. So you need to find out how much relief is there and ready to market yourself. Some specific needs related to interventional pain management. It looks similar to the regional anesthesia, but it is not, absolutely not. There is no role for blind epidurals, which we all are very fond of. So, C-arm fluoroscopy is our eyes. Fluoroscope is our eyes. In some places, ultrasound and few people are also using CT scans, but still the standard of care is C-arm fluoroscope. That too of a very high quality. Not by the routine C-arm fluoroscopes which are available in our OTs. They are very useful for the orthopedicians because they need to see the head of femur or the shaft of femur, which is otherwise also maybe visible. But what we are doing doing very fine work. So we need a very high quality C-arm. And last but not the least, putting needle is easy. It is not rocket science to understand how to do a spinal, but how to manage a spinal, we are talking a lot, and we still need to learn a lot. So, some specific advices for my friends who want to come in the pain medicine. Be ready to be humiliated. This is again very contentious issue because initially when you start practicing pain medicine and you start calling yourself a pain specialist, you are being put for the test by every ortho-neuro colleague on everyday basis. So, but that gives you the fire to go ahead. You come back, you read again the term what he was talking about, and this is how you learn because our basic training lacks the exposure to pain medicine. Second is be ready to work very hard in the known territories. You need to read a lot. I have already talked about the money part, and remember here there is no one to save you because though we very often complain that every blame is being put on us that mareej bahar nahi aaya, mareej mar gaya, anesthesia se bahar nahi aaya. But here bouquets are yours, so are the brick bats. Be ready. Patient will come and say, Doctor Sahab, aapke ilaaj se koi fayda nahi hua mujhe. So you have to feel. And it is a full-time job. This is the single most important thing which I would like to stress upon, that it is a full-time job, a bit of anesthesia, a bit of critical care, a bit of pain, it doesn't work that way. So this is the bad part, rather harsh part I am talking about, but I believe that this is our extended family, so I can at least talk it here, if not elsewhere. So the threat which the pain medicine is facing by the weekend and cadaveric courses in the interventional pain management, because unfortunately, like in critical care part, I work in the government setup, and it has become a common knowledge in the government circles as well as up to the public that ventilators are the life-saving thing. If you get a ventilator, that it means that your patient is safe. But we all know that ventilator is only a part of the whole train. So without that, you can't do this. By short-term courses and by online and some foreign agencies accrediting you through their courses held at the exotic location like the Netherlands and the Hungary. So, and unfortunately, because I believe that this is our super specialty, the eligibility in most of these courses is the plain any degree of medical in any field. So this is at least not acceptable to me. This is just to show an example what is going. Have we come down to the pizza delivery houses that you get one and you get three, then you will get discounts? So unfortunately, it is happening. Yeah, get 3. So this is what we are doing with our specialty. So these are the some excuses which I often come to know when I talk to the mentors of these courses, because again with the permission of Dr. Vijay, because he was talking about the inclusiveness of the society, and I am talking about very selfishly. Large number of patients are there, so we need large number of pain doctors. My question is, sir, that we have a large number of cardiac patients also. Are cardiologists ready to teach interventional cardiology on the weekend courses to us? Once upon a time, I started second one. So for my personal vendetta, should I harm my branch, my parent specialty, and my future generations? No. We should not hold back our knowledge. Teach everybody. Who else is ready? Once I am just telling you my personal own example. One of my ortho colleague, he asked me to look, I am going to give a thesis on transforaminal injections to one of my resident. So please, you teach him. I mean, okay, I am ready. But at the same time, I am giving a thesis to my resident on the laminectomies. Are you ready to teach him? So he chickened out. So, yeah. So my take on these excuses that teaching maybe is easier than the treating. Because cadavers don't cry, they don't bleed, and they don't even die. So this is the question which is for you, for the whole house of anesthesia community. We have done this behavior with the critical care. It has gone out of our hands. We no longer we had the critical care units in most of the departments. We have done this with emergency medicine. We have done this with the resuscitation part. Someone else has come. We discover things. Someone else comes. We give him, and just things are going on like this. So, are we going to do the same behavior? And if you do not own, protect, and support your own kid, your own outgrowth, someone else will. Then you just remain empty-handed, working with the thing of the parent anesthesia part, which you know all. No other specialty accredits in weekend courses. There is no course in any specialty. You tell me one. There is no course. This is an open question for everybody. But so why do we? So now this is the future, the way forward, which I believe that for those they are working in the government, public sector, they should assign someone. There must be someone in your department, for all the seniors, who is interested, is having interest in the chronic pain management. So please assign him for do this. Please make him free for this thing. Open a pain clinic in the pain OPD. I have very often seen pain clinics working just adjacent to the OT. Look, you look after the OT, and in the meantime, whenever you get a patient, you just give care to him. It doesn't work that way. You need to have your clinic in the main OPD area of the work. Refer all your cases to that person for chronic pain, and in return, he will tell you, refer you all the difficult cases, all the critical care cases. We can be expert of only one field in all through our life. We cannot become experts in everything. I don't know regional anesthesia much because these tab blocks all they seem so difficult to me. Though I do cervical cordotomies, but I don't do how to know how to do the tab block. So, and try to start some government-supported MCI recognized courses like PDCC, maybe DM in the near future in the government setup. Those they are in private sector. Please try to start the FNB courses, DNB courses, especially the FNB courses because they are for the super specialty. And we can here take a cue from the ophthalmologist. I should tell you, in retina, there is no government course available in India as of now. But multiple eye centers are giving fellowship in retina. And people are going there through a proper exam and coming back and doing very well. So we can take a cue from there. And there must be someone from in your city who is doing pain nowadays. So please refer your cases to him. So next time when your ortho or neuro colleague asks you to give an epidural and with mixing little bit of steroid, please refuse politely and support your guy. That until unless we say that, look, I don't do spinal cases, my Chintan is doing very well than me, so we cannot go forward from here. So we need to decide. This is the question, pertinent question. We want to make the pain technician who pokes needle here and there on the whims and fancies of ortho-neuro people, or we want to make pain specialists comprehensive, with the comprehensive knowledge of chronic pain management and other parts. So don't repeat the same mistake with pain medicine, which I have already said. Okay. So thank you. And I am sorry if I have hurt some sentiments, but I believe that this was my wake-up call for our community. So that's it. Yeah, please.
Have a seat. You can sit down and give that to you. Yeah.
On that thing, actually there are two ways. The easy way that you go and request a ortho people and they will never send the patient. And moreover, when I was preparing for my MBBS entrance examination, one of my teacher used to say, difficult questions are difficult for everybody. Go for the easier one. So you don't get a easy patient on the referral basis. So the only way to get the patient to go to the no GP. You go to the patient, win the public. The effort which we are making by the newspapers, by the articles, by beating your own drums in front of everybody. Look, I do this thing. I know how to treat the neck pain, and with your working, because patient is the biggest loudspeaker of your work. A satisfied patient with the, and it is a very gratifying branch because it is nothing better than having a smiling patient after the treatment of trigeminal neuralgia. So for that matter, any chronic pain patient who is suffering for years, if you do something good for him, he will be the biggest loudspeaker, mouthpiece for you.
Yeah.
I would like to talk on three things, if you permit me. First, during my MD from BJ Medical College in Pune in 1989, I started a pain clinic in the department. Three big names I would like to take. Dr. Balavenkat was my JR. Dr. Maruda Chalam was another JR. I feel he's somewhere in Australia now. The Australian people might know him. Yes. And my lecturer was Dr. Anjali Kusurkar, who is in UK now. We used to go every day in the evening and go to the X-ray department. We had an image intensifier in those days. And thanks to her, she used to wait after her regular day duty. And at 5 o'clock, we used to get an appointment in the X-ray department and we used to give all sorts of blocks. Secondly, I happened to come across this group because of a PainCon which I had organized in Nasik in January. This conference was organized under the banner of ISA Nasik, and we had taken the Orthopedic Society, the Gynec Society, the Surgical Society, the Onco and the Neuro Society under our banner. And this conference was organized by ISA Nasik. And I was just looking at all the anesthesia groups on Facebook, and that's how I came across this group. And I just asked for I feel Dr. Gupta finally accepted my membership. And then I put up this PainCon thing on that. During the PainCon, I feel I came to know probably that was for the first time in the country that anyone was having this sort of a conference. I'm not sure, maybe you can help me. But Dr. Kailash Kothari and even the national president had acknowledged that we have not heard of this sort of a conference. So, being very frank about it, even my executive committee members were reluctant to have a PainCon.
Yeah.
There's only one person in Nasik practicing pain. Why do you want to have a PainCon, have a conference on pain? Well, see, I feel this is the best way if you're going to not support your own colleague. He may be only one. But I feel it makes sense that you support him and let people in the city know. And frankly, we had about 450 delegates coming from all over Maharashtra. I mean, I'm not sure anyone from here was there, but then we had a fantastic response. Yeah. The orthopedic, gynecology, each session was on their topics where they require a pain consultant. They discussed on their point of view, and then the anesthetists took over. Yes. Dr. Gedu, Kailash Kothari, I mean, all these people had come down. Yeah. So I feel this sort of initiative...
Certainly, sir, they will help.
Will definitely help your...
you need to make people aware, isn't it? If they're not aware that there are pain specialists, how will they know? So I think that was a very good idea to actually get the gynecologists, orthopedicians, neurosurgeons. I think that's important to get awareness.
Yes, and I feel there are already 2 more people who have settled in Nasik now. There are 3 people doing pain.
Okay,
And I feel they probably are pretty happy from what I understand.
the more the merrier. How many people are there, it will be good. But they should be completely focused on this thing only.
Yeah,
They
so
can't do everything.
Yeah.
Yeah.
So if Dr. Vijay has something for Nasik, please let me know. We can do something.
Oh, thanks a lot. Thank you.
Yeah, I think you can actually speak to Vijay after that.
Just a
Now, Vijay, yeah.
couple of things. The FNB, which Anurag was talking about, if you look at FNB spine surgery curriculum, the interventions are there.
Okay.
Okay, so I think we need to set it up like a specialty or a good sort of a super specialty with the most of people coming from anesthesia. Otherwise, we'll be losing out on that.
Yeah, I think you people should take a lead. Take a lead and go for it. I think you form a
That's
society.
right.
I mean, what we can do from our side, we'll obviously support.
Oh, thank you.
But if you are actually planning to actually go ahead, just please go ahead.
And
It doesn't need to be a government thing.
It doesn't
Yeah,
have
you
to be.
can't.
Even in private
You can never
sector,
wait for
yeah.
government to actually start things for you.
Sports medicine has an
Yeah.
FNB. I
Yeah.
think there is some sort of high risk obstetrics. It's all FNB coming up actually. So I think it makes much sense to have pain
Absolutely.
as an FNB. As Anurag
Yeah.
said, it's our responsibility to do
Absolutely.
it.
We have
because
to
it's
take the
from
lead
private
in that.
sector.
Yeah,
Yeah, that's
yeah,
true.
yeah.
And in
Okay.
terms of the frustration, what people are talking about in terms of not getting patients, there's a famous saying. It's kind of a meme in the pain society. In that a senior pain physician from Mumbai, he went and spoke to his friend who's a surgeon.
Yeah.
He said, "Sir, I'm not getting any patients. What to do?" He said, "Well, wait for 3 years, and then you'll get used to it."
Yeah,
So I think
go
that's,
for it.
that's,
I think,
that's the,
Yeah.
the state of pain medicine
Yeah.
at this point in time. But I think it might change.
yeah, I think be aggressive. Be aggressive about it. I think if you want to be, you have to be. You want to look up or you want to be seen. I think you need to be a bit aggressive about yourself. Now, I think got another presentation which is not there in the program, and it's by our chief guest here, and it's about rural thing. That's what actually struck us because you're talking about rural thing. There's someone who actually does a lot of work in the rural areas as well with palliative care. Okay, this is something which not like pain, not everybody can do. Similarly, I don't think people can work with patients with cancer who actually are smelling, they are dying. Okay, here it's someone who does that regularly. Yeah.
Good morning, everybody. Sorry for Shiv. Sorry for literally barging in because with the sessions on pain going on, and especially if you're practicing in India and that too in a rural setting, because I saw all those statistics about how people can't access, pain relief. So I do a lot of palliative care, and I've been doing it since 2006, and I really know what are the barriers to providing good palliative care. So I'll just rush through it. Situations can be very, very volatile, right? Especially when you go down to the villages, situations are pretty volatile. I practice in Jharkhand, and the place where you practice, that place becomes very important because especially when you're treating pain, when you're dealing with death, when you're dealing with the dying people, the land, the people, the culture, their local beliefs, their practices become very important. Like a simple thing, like if you go to villages and if you just give a tablet for pain relief, the villagers will say he's not a good doctor. Because a good doctor is one who gives an injection. So you got to think that way. You got to think very locally. So we started off way back in June 2006 with exclusively by unpaid professional volunteers. And we started facing a lot of problems. It was a virgin society. People really didn't know what palliative care was all about, what pain relief was all about. And forget the general public. Most of the doctors didn't know what palliative care was all about. And when we started going down to the villages, we were viewed with suspicion. कि इन लोग आखिर आ क्यों रहे हैं यहाँ? Doctors are coming down with a big team of nurses and volunteers and actually providing free services. दवाई भी मुफ्त में दे रहे हैं. यानी कुछ तो गड़बड़ है. Your colleagues also would speak behind your backs कि देख अपना practice बढ़ा रहा है या अपना popularity बढ़ा रहा है, what not. ऐसा होता है, and when it happens, you know that you are in the right direction. And the worst part in India is lack of availability of morphine. But that does not mean, just because you don't have access to morphine, doesn't mean that you won't do palliative care or you won't do chronic pain relief. Right? Morphine, no doubt, it's a very good drug, no doubt. But that doesn't mean that there are no other available drugs. Do you have any idea about the number of painkillers that you can get off a local counter medical shop without any prescription? Have you actually used all those resources before crying for morphine? And even if you do have morphine, before prescribing morphine, please ensure that it is the consistency of its availability. Availability is not an issue. The consistency of availability is an issue. Once you start morphine on a patient who has chronic pain, and 1 week after, when the patient comes back to you, you say, I'm sorry, my stock is over. That is worse. That is worse than starting him on the morphine in the first place. This is a classical scenario where we had gone, the patient is inside in that green sari, CA cervix, with a volunteer kneeling down. And these two ladies have no business whatsoever. Padosan ki hai, and just see their looks. This is how they look at you with suspicion. And God help you if anything goes wrong. Aapne ek injection diya and the patient dies due to some other cause 2 hours after, you can never enter that village, ever again. Lot of challenges. Getting down to the villages, there are no roads, and this photograph was taken in winter, where when the rivers are actually, converted into small streams, and this is how you cross. So accessibility. We go to small schools and all, and we hold, this was a cervical cancer screening camp which we held. And this is how patients come. See again, crossing down to a village. We then go to the village, see that bunch of boys out there who have nothing better to do but to, give us very dirty looks. And then we go to the village, talk to, before going to a village, we, have a key person out there. We sort of line up the program. Then we select one nice area, drag some chairs out there, and then the patients start coming in. And you can't refuse any patient. Just because you think that you're a palliative care physician or a chronic pain physician doesn't mean that you won't see, anybody with diarrhea, for example. We have camps for the elderly because most of the chronic pains are in people above, say, 60 years. Right? There was this nice study which actually said that more than 80% of the people above the age of 65 have one disability. And that goes to more than 2 if you're above the age of 70 years, and so on. Privacy. When you are, communication is something which we are never taught of in medical schools in India. But communication is a very, very important part of medicine. And especially in pain medicine, you've got to listen to what the patient has to say. Because the pain is just not physical. Physical pain is just 25% of the pain. The rest 75% is made of spiritual, then psychological and social issues. We forget that 75%. Our focus is on how to give a block, how to give some new medicines, and that's about it. We are forgetting that 75%. Just by listening, by empathetic listening, you cure a lot of pain. So, say communication in such scenarios, it becomes quite difficult. So what is the logical approach? Maintaining eye contact, maintaining a proper, hierarchy. Like if you stand over a patient and look down at him, naturally he would, that's a hierarchical, that's a psychological hierarchical problem. And this photograph was taken way back in 2009. You just see the time, 10:24 a.m. and this lady had cancer of the cervix. This was in the Purulia district of West Bengal. I started talking to her. And the same photograph at 10:40. I had to stop conversation because the rest of the villagers, just came along. So, but this is India. Domiciliary-based interventions. These I give a huge emphasis on going down, especially if you're dealing with chronic pain, be it terminal pain, be it chronic pain due to non-terminal diseases. Unless you go to the homes of the patient, you cannot treat chronic pain. Reason? Once the patient comes to your OPD, the patient comes with a mask on, right? You never know, like the patient has actually got up at 6 o'clock in the morning and he has called his rickshawala to help him climb downstairs, and he has asked somebody else to help him on the rickshaw, and then he has traveled all the way to your OPD where he has stood in the line for say 3 hours, and then our Mr. Heb doctor comes in and just gives him 5 minutes of his time. Do you think it's justice? But that's what happens, isn't it? So domiciliary-based care is important because there you actually know how the patient lives. What is his income? What are his constraints? If you tell a patient, oh, you have to lie in a very quiet area, it's not possible for him because in that small room, 8 people, stay in one room. Domiciliary-based interventions like peritoneal taps. If I ask this lady who lives, almost 14 kilometers off the main road to come down to my hospital for a therapeutic peritoneal tap, she can't do it. And when you go down there, you won't have fancy equipment. So you got to do with the local bartan, boiled, cleaned. Even pleural taps, done in desperation. And this gentleman who is holding that lady is actually her husband. Metastatic breast cancer with malignant pleural effusion with dyspnea. And then for the elderly, escharotomies at home. Eschars, especially grade 4 bed sores with thick eschars, are painless. You can easily do a escharatomy at home. It's painless. Housing. How many of you do not have a life insurance policy? 2 people don't have. The rest of you have nice, fat insurance policies, savings, isn't it? What is the guarantee that those savings would help you when you're lying alone in bed, dying of a terminal disease? No guarantee. But then you have huge flats. You have booked, like Manisha was telling me, she has booked a nice flat. Everybody has. Koi flat book karta hai, koi bada ghar banata hai and everything. Right? How much can, say, above when you're, say, 70 plus or when you're 80 plus, do you think, what are the chances that you will be with your family? Almost zilch. Your children would be away. Maybe your partner, your spouse will no longer be there with you. And what are the possibilities of maintaining a 3 BHK apartment if you're alone, 70 years plus, suffering from osteoarthritis or blindness or whatever? Can you maintain a 3 BHK apartment? So what are your needs, actually? And that is how, this is our center. And this is something which I came up with. I estimated that you need approximately 250 to 300 square feet of area. That's about it. For a couple, elderly couple. This is where we hold our, OPDs and all. And this is the interior of that. The interior. And the best part of that housing is that if you don't feel like staying there anymore, you can just pick it up on a truck and take it away. You have mobile caravans and everything, but those are pretty expensive, 50 lakh plus. This cost us around 4.5 lakhs. Non-cancer palliation, okay, I'll just skip these. Okay, just one. Whatever you do in India especially, should be locally available, should be acceptable to the patient as well as to the family, accessible and affordable. These things are pretty important. Fancy stuff do not work. If you think that they can afford a implantable pump or something of that sort, no, it's not going to happen. So innovate again. And this syringe pump was donated to us by a hospice from Scotland, and we used it for a couple of months and then gave up on it. Because these were designed to work at certain temperatures, at certain climatic conditions. In India, they frequently get jammed up. And once they get jammed up, you get a call in the middle of the night saying that, wo to kaam nahi kar raha hai, light blink karna band kar diya. And do you think in the middle of the night you will travel all the way, say, 30 kilometers away in the middle of a village and rectify it? You can't do it. And that is why then we thought better give it up. We load up the drug in a big syringe and give it to the patient's relatives. And they are very meticulous. They are more reliable than these pumps. We tell them, har 6 ghante mein inject it. Inject it through a butterfly needle or a scalp vein set which we have fixed on the anterior chest wall. And they do it. Technology again, technology versus innovations. This child with cerebral palsy otherwise would need a very expensive walker, to mobilize. But then with this small toy which his father made for him, he can walk around. 100 rupees versus say 25,000 rupees. CA breast. What is that? This lady, when we used to do dressings for her, she used to get so frustrated and she used to, simply take it off after 2 hours. Because the dressings were so heavy and the cutaneous extent of her cancer was so much. And then suddenly I decided, why not use sanitary napkins? They work fantastically, super absorbency. The only problem she faced was the margins of the napkins were sort of stiff and they used to irritate her skin. So then we covered it up in a soft cotton padding. So again, it's just innovations. The best thing about innovations is that you only innovate when you don't have all resources. So it's good to be in poor resource situations. Like Dr. Surajit Giri, he's been innovating. Using banana leaves for dressings. Very good things because these are semi-permeable. They let the air pass through. And using haldi paste on chronic wounds, chronic beds of wounds. It works, believe me. This lady, she had CA cervix and she used to smell a lot. She had pyometra basically. So what her son did was, maa ko uthaya with the charpai and put her in the courtyard where the buffaloes and all are tied up. Because the mother used to smell such a lot. And I don't blame his son because one small room with say 5 or 6 people living in that room, they couldn't stand the smell. This lady didn't have pain, but she couldn't sleep. Do you know why? Any guesses? She didn't have much pain, but she couldn't sleep. Now, suppose her son had come to your OPD and had told you that, Doctor Sahab, aapne to dawai ka dard ka dawai de diya, but maa abhi tak so nahi pa rahi hai. So what would you have done? Alprazolam, clonazepam or whatever. And 2 दिन बाद वो फिर आता और बोलता माँ अभी भी नहीं सो रही है. पर जब तक आप इनके घर नहीं जाओगे आपको पता नहीं चलेगा कि माँ सो क्यों नहीं रही है. Flies. So what we did, we spent 100 rupees and bought her a mosquito net. And Ma could sleep. Team approach. You can't be a hero alone. You got to have supporting staff. My team, OT technician, nurse, the last guy is my driver. He's also part of my team. Everybody is important. And this is how in India, as I said, your things have to be accessible, available, affordable, right? Because people share their rooms with their cattle as well. So don't talk about big things in India. Talk practical. Use the local people of the community to come and help. Because as I said, pain is not only a physical dimension, it's got a social dimension also. Depression. Chronic pain leads to depression. So when the local people come and help you out, depression also sort of, they treat depression that way. Injections are pretty important in Indian scenario. Unless you give an injection, you're not worth it. But try to educate the people. See, here again, education of the family members. You can notice the syringes on the bed, kept on the bed here. So I'm teaching them how to use those syringes for subcutaneous use. Now, this is just an example. This lady, she had a malignant tumor on the scapula. And see, we put in the butterfly out here. And this is our nurse. This lady had accepted that she's going to die very soon. She had no problems with dying. Because she was very spiritual that way. She believed in God. She believed in fate. She said, "Ye mera karma hai." She believed in the so-called karma theory. It's gone off, huh? Okay. So, her only problem was that वो उसके घर के सामने ठीक एक बगीचा था, and she used to grow vegetables on that. Her main thing was that कि मैं मर जाऊंगी तो बंदर आके मेरा वो सब्जी खा लेंगे. Every morning she used to sit on this charpai guarding that, small garden. And then we sort of convinced her. We brought her daughter-in-law and made the daughter-in-law promise her that कोई बात नहीं अम्मा, आपके चले जाने के बाद भी we will guard your garden. And then she was at peace actually. So letting go is also very important. Dyspnea. This patient has dyspnea, and do you know what his son is actually doing? Standing beside him, very important part of therapeutics. Never leave a patient who is having dyspnea alone. Right? Any patient having dyspnea is scared. Don't leave them alone. He's standing beside him and massaging his back. Makes a hell of a lot of difference. Try it. Empowering. Oral ketamine being given by the wife. It's not that we don't have drugs. We have drugs. Only that we keep crying for more and more and more. We are like spoiled children. Presence of the family. But then most of us will not be this lucky. Dying at home is going to be a privilege for most of us. Most of us are going to, die very painful and very lonely deaths in intensive care units. That is our fate. So do you have any plans for that? Have you made any plans for that? Think about it. Thank you.
I think I feel very privileged to be associated with Abhijit. And I think as a society, I think we feel very privileged that someone is doing that kind of work. I can tell you, I cannot go next to such patients and provide that kind of care. I don't know how many of you will be able to do it. I think it is amazing. As a token, we are not very rich. We are a new society. Okay, we have just started. We have, whatever is done by the registration here. Okay, we have small amount of fund, and we would like to give some part of our fund to Abhijit as a token of our appreciation. Dr. Alok. Thank you, Abhijit. Thank you. Okay, we move on to next session, ma'am. We're waiting for this, and we are very sorry. We have actually taken a part of your time. We're going to move on to the medical legal sessions. I had actually thought of actually having it as a panel of senior members. So can I ask the members, our senior members, to please come on the stage? Dr. Dua, Dr. Alok. Where is Dr. Pankaj Mehta? Ma'am, आपका presentation अच्छा से Dr. Vivek Gupta, Dr. Mully. मैम का सर हमारे वाले हाँ वो निकाल लीजिए
Please, you have take.
ये इसको ले जाओ, उसको बंद कर दो, सर बंद कर. What? Sorry, yeah. You know, when we announced that ma'am will be coming here as our expert, and we had asked for a few questions to be sent. So what she has done, she has actually collected, and she'll talk about those questions or going to address those problems to us. Yeah. Acha, okay. Thank you, ma'am.
Well, thank you, Dr. Anil. I'm privileged to be here, and after the talk that preceded this talk, I'm humbled. And I would like to be associated with these people when I retire from my practice. Because this is what we need to do, especially if we feel for the poor and our own people. Thank you. Now, the talk that was given to me was, are we protected? And the medico-legal issues. For the protection, I would only like to say, we have our insurances probably, and our associations are trying to help us by providing some guidelines or even giving some expert opinions when they are asked by the members, especially most of us are in the private sector. The Indian, I have been the chairperson of the Indian Society of Anesthetists Legal Cell and also the Legal Cell of Indian College of Anesthetists by just having a degree in PG Diploma in Medical Law and Ethics, and I have been working on it for last many years. So there, I would say that we do contribute a lot in whatever aspect we can do. Coming to the second, the medico-legal issues, we'll be going on to why we get involved in the legal issues whenever we cause an injury inadvertently, a death that occurs. Maybe it was we are not negligent, but this term negligent does hurt all of us. So why we are called negligent, it is a legal nomenclature, I would say, because man is the only animal who wanted law and order. And there came the legal duty. There came the legal rights for the people who were under it and the legal remedies. Starting from there, why is doctor sued for negligence? Because he is under legal duty to exercise diligence, and this is a contract by implication. Whenever there is lack of proper care and damage, it does cause liability for breach of the professional duty. And the patient, when he comes to a doctor, he trusts that doctor has skill and knowledge. So as I told you earlier, legal rights and legal duty. Legal rights are the provisions provided by law to protect the interest of its citizens. And legal duty is a duty the law gives to every person to respect the legal rights of others. So where there is legal right, there is legal remedy. And this maxim, ubi jus ibi remedium, is very popular in legal parlance. So legal remedies. Doctors have been sued world over under civil law and law of tort. Medical councils have crept in. There are consumer courts which came into force in 1986. There was a lot of hue and cry through our IMA and all that, why doctors are being included into it. And definitely there were certain justified reasons which doctors were advocating. But the fact remains the doctors were included into it to grant compensation to the sufferers. Whether it's right or wrong, this is not the forum to argue about it. The compensations that came after it through the medical council is debarring from practice. And I did come across cases in UK, US, where they have been even, imprisonment granted. So it has been going, and we have been copying from British, from where we inherited most of things. But today is the day we are copying from everybody. Whenever there is a case in the court, probably we are trying to look at all the cases which have happened in US or anything without even understanding, yes, whether we have those facilities. But there are some safeguards in place, which I would like to bring to you. And there were cases not many years ago, when in case there was a death, the relatives used to approach police and police used to arrest anesthetists. So that particular thing was in the Supreme Court judgment. They said that doctors will not be dealt like this, and that was a very welcome judgment for all of us. Now, no, because you know what they would do it? They will arrest a doctor on Saturday or Friday when there's a holiday, so that just to give comfort to the relatives who are in anger. So we have had under a lot of forums, we have interacted with the police, and they told us they do it not for harassing the doctor. They respect them, but to even protect them from the assault of the others. So that does give us a little relief. We all know to err is human. No man is perfect in the world. A person who is skilled and has knowledge over a particular subject can also commit mistakes during the practice. And remember, law recognizes the error of judgment is a word well defined there. Treatment done in good faith is again another term. And there are various sections under the law, Section 88 and all, which are protective for the doctors. They do, under criminal negligence, they try to put FIR, book us at 304, 304A, but there are other protective sections also, under which the doctors, if your lawyer is good or there are some advisors to you, you know how to protect yourselves under those sections. Coming back to anesthesiology, which is our branch, it's a high-risk specialty. I became an anesthetist because my husband was a surgeon, and probably I followed suit, and he felt that we would make a very good team. And I would say we worked together somewhere when we were together in Algeria. But I have learnt a lot from him, and I find him apart. He has been my strength because, yes, it did make a difference being associated with a surgeon and to compare him with many other surgeons we all see. So, yes, there was some things I learned. The anesthetist shied away being in communication, as already mentioned. There was interaction between patient and anesthesiologist is always limited. Even in today's era, in my own department, how much I communicate, I find my people would just want a junior person to see and do a pre-anesthetic checkup. They won't like to go. Even if I say you have posted 2 people, at least the senior go and see, they would try to shy off. This is the situation even today of the anesthetist. And it is very common that we run our PAC clinics. The anesthetist who sees the patient may not even administer anesthesia and may not be even present on that day in the operation theater to say hello to that patient. So coming to the interrelationship between anesthetic practice and the law. PAC is all about communication, all about doctor-patient communication and relationship on which the first premises of law is based. And this is the time when we could interact, and at least in our practice, when I do that, I have included that this is the time when we even talk about the consent process, inform about the technique of anesthesia that we are going to use, and also tell them about the risk, even the risk of death, in a way not that you may die, because even an ASA grade 1 has died after spinal anesthesia, we know it. But by telling them that your, incidence of accident is so much as when I travel to the road and I don't know whether I'll reach home. It causes a personal touch, when it comes, it matters. We got to know. So consent by law is a contract for services, and it is challengeable under Indian Contract Act Section 13. Remember, consent is very shabbily taken by all the doctors, whether it's a surgeon, whether it's an anesthetist. When you look at those consent forms, some resident who doesn't even know how to fill, he fills it incomplete. And these are the consent forms which are waved at the doctors in the courts, and they are challenged because the communication is very brief. No, they just fill it as a matter of just documentation, and these are where they are, failing and also losing the cases in courts of law. Consent is very, very important document. Choice of technique, talking, we all know that we got to talk. And on this, certain legal principles are also based. When we talk of various decisions, there were 2 major principles, legal principles. One was Bolam principle, and this was based on wherever there are 2 opinions of doing a particular case. I may prefer to do it under general anesthesia, another anesthetist might prefer to do it under spinal anesthesia. We all know that all cases can be done like that. It's a personal preference, but there are also certain standard of care which is which has been directed or given to our by our associations and societies and even our academic books. So what is the standard of care in your setup is very important, and all of us have to set down that standard of care. I'm working in a rural area, as we listened in the previous lecture. I may not give spinal, I may just do under a local block or anything, giving a little local vocal, what we used to talk in our residency days. So that is the standard of care in rural thing. So let us put down now, because of the legal things coming, put that in our papers that I belong to a primary care hospital. This is my standard of care. There is a basic minimum equipment that I'm supposed to have. I remember in 1992, probably this in Director General of Health Services in Delhi, they did issue a document and circulated it all over Delhi. And ETCO2 measurement is not a part of it. Now we know that so many accidents occur because of disconnections. So it has to be brought apart, especially in the Delhi setups. In Delhi also you will find the primary health, the equipment according to a primary health center. So we got to define our own standard of care. That's very important. And previously, when there are two ways of doing it, Bolam principle was a case of a person who was epileptic. So again, there were two ways. Some people would give muscle relaxants, others will not. And in this case, because the muscle relaxants were not given during the treatment, when they give the electric shock, the patient sustained fractures. So it was debated in the court of law. Some expressed said, yes, we don't give it because it's not very safe to give muscle relaxant. The other said, no, you don't give it, this happens. But then it settled. When there are two opinions, it is not for the court to decide which one is good. It is your own expert body will say which thing you should have used, and their opinion when given to the court is acceptable. Then came in contrast recently from England, Bolitho principle, where now courts can even, it was actually a case of a 2-year-old boy who was in ward, and probably the pediatrician was needed when he was going through respiratory distress and all that, and the pediatrician treated that child conservatively. Patient sustained hypoxia and cardiac arrest. Again, two methods of treatment. Should he have been intubated early? Would he have survived? Now the courts, according to this principle, may even start asking, was it right to do it like this way? So this was what Bolitho principle is latest, which has come into the thing. So from Bolam to Bolitho we have moved. Then availability of equipment. Many cases, defibrillator not available. And there is a case from Gujarat where probably patient was hypertensive or whether the disconnection occurred, because it's very difficult to say what exactly happened because there's a lot of cover-up that happens with documentation, and documentation is the only thing. But one thing that was caught was that defibrillator was not available in that particular setup, and this is from India I'm saying. And the anesthetist conveniently said, it's not my duty, it is the surgeon should have arranged it. So she was asked, did you tell the patient about it in the informed consent, that you didn't have a defibrillator in case this happened? No, and the compensation was granted. But yes, you erred here. So these are few points which all of us can do, but we don't do it. That is where it is. Again, there is a case report from UK, where the defibrillator was not even in the vicinity of the OT. It had been given to some cath lover and thing. And this question, why it was not in the theatre, also probably the compensations were granted. There are small little points which are caught. And it's not our probably the errors that we make, but yes, we don't look at these things. So management of complications, we all do. Complications will go on occurring the way the patients have comorbidities, they do happen. But I know even the real scenarios where, a spinal is given, the senior knows the patient has an aortic stenosis, tells the person, isko small dose de do, ya not even mentions the dose, isko spinal de do, niche ka hai. And that person comes, doesn't even know that patient has aortic stenosis, just gives a 3 cc of this. And I've seen immediately those people not even ready with their arterial lines or any monitoring, and patient succumbing after a few hours. You manage to resuscitate with that, but that is the way unplanned anesthesia still continues to happen in many setups, and even in good setups at times when you depend too much and don't communicate even what are the alerts in that patient, and go ahead. This is the supervision of a juniors is also very important. Blood, availability of blood. There have been cases when the cesarean, The blood was not available, patient bled to death, even though it was not arranged. And they said, it's a duty, you should have done it. You know that some cesarean, you cannot predict who's going to have a postpartum hemorrhage. So why don't you routinely have it? And there, again, the compensation is granted because of, they would call it negligence of the doctor. Documentation is the legal proof. You may fudge it, you may do whatever it is, but they have means. The means are mainly your internal, whenever an internal inquiry occurs in that hospital, there are many facts which come out. They may be, not told or revealed or anything, they try to cover up by documentation, but to the courts, it is a documentation which is a legal proof. And I'll come to, there are certain documentation pitfalls of different timings at the same time, two different doctors writing different timings and all, which goes against you. Post-operative follow-up, again, we all leave our patients at the post-operative recovery room sisters. And they said, should anesthetists depend only on them, because he has to go and start another case. And there was a case where probably the post-operative nurses had gone for coffee together. There were 2 or 3 nurses. A child sustained probably hypoxia because he had some breathing difficulty, not tackled. Anesthetist was busy inside. And the court decision ultimate was that when the anesthetist has handed over to the post-operative nurse, I would recommend that do write the name of the person whom you are handing over. That post-operative nurse is supposed to be competent enough to handle your post-operative cases, or at least inform you if something goes on. If that is not done, the anesthetist is not guilty. So there are few cases which you can pick up some clues and go ahead in your practice. So as I said earlier, there are prerequisites of legal liability, doctor-patient relationship, there is a duty of care, there is foreseeability of harm, and you are prepared for it. And if the harm occurs, how do you manage it? So everything has got a legal synonym there, whether it's a primary liability of the doctor or a vicarious liability of the hospital, because the hospital has employed the doctor, but hospital has to give us adequate staffing, the infrastructure, and they say, suppose I ask equipment and then the hospital doesn't give me. It's like a defibrillator, which is very important that they don't give you. There should be a proof with you to say that you wrote that communication repeatedly and keep a proof. That is your proof. Hospital may not give you, then hospital is liable. But you have to have your proof that you demanded it. So causes of mishaps, when you look at, there are human factors, patient factors, systemic failures, and they all breach the patient's safety and cause problems. So medication errors, we all know, airway mismanagement is very, very big issue. Patient factors, we all know, whether it's a cardiac, diabetic, anything can contribute, but I think it's mainly the airway mismanagement, unanticipated difficult intubation when you really get into panic mode, and even if it's lying right in front of you, you will not be able to do it. Equipment failures have been there with ventilators, with anesthesia machine. I have seen even the bursting of a valve and suddenly a patient getting a pneumothorax on the table, and that anesthetist was bright, immediately detected there was a pneumothorax and acted, and patient was saved. So these things will keep on happening. Infusion pumps, put at rates which were not acceptable. The disconnections of the intravenous lines which got unnoticed under the drapes, these are common incidents which happen because these days you will find anesthetists, most of the anesthetists, when they are long cases, they get bored. So they are on their phones. They were, rather than looking at the patient, which we used to do with a pulse in hand. In 77, I joined this branch, when we were sitting and looking at the chest movement, and we were looking at, holding the pulse. And so we have come a long way. But then these things have now started coming. Human factors, I think most of them I've already said. Yes, the fatigue is one of the things, 24 hours duty. And again, a real incident when during the MD days, it was a surgeon who told to it was hand ventilation, the anesthetist fell asleep. And it was a surgeon who said the patient is not bleeding. So these cases are true cases. They happen world over. So more than 50% occur because of human factors, whether it's communication, assessment, or training. Fatigue, inexperience, distractions, and recently I read distraction that he was the person whom this anesthetist was monitoring inside the theater. He wrote a note about it in the Facebook. And the patient died. When the inquiry came out, they found, at the same time when this instance has occurred, they found a Facebook notification by this anesthetist. Remember, if we are going to be caught somewhere or other by the people who are more intelligent than us. Failure to check an anesthesia machine, yes, and fluid mismanagement. Again, I think this is a slide I got from Medanta. Systemic factors, timeout procedure, wrong site, wrong procedure. They still happen if you are not meticulous in the preoperative area. And in local cases, they are bound to happen more because surgeons think they are above par. So many surgeons would not even bother to fill that safety checklist. And unsafe design, unavailability of basic monitoring devices, and all that. So everything we need to do is improve processes, align our policies to safety, and improve infrastructure. Now coming to the common incidents. There have been cautery burns. I'm sure you must have seen thermal burns. You have seen cautery burns. Our own doctors' wives, after a spinal, somebody being very compassionate, after spinal on the paralyzed limbs, gave them hot water bottle, and there were burns. So these incidents happen day in and day out with our own people too. Airway mismanagement, as said earlier. Anesthetic procedures, complications. Nerve blocks, remember nerve blocks, we are in it like anything, and there have been pneumothoraxes. And I've seen, when I was in Safdarjung Hospital, when doing my post-graduation, a patient who had given a supraclavicular block had a pneumothorax. He had come to get his plastic surgery on a small little finger. He refused to get a surgery then. He was in ICU for some days, and they said, I don't want the surgery done. So these things happen. Nerve injuries, they are the big source where the litigations occur. Eye injuries, dental injuries, the common allegations that we found when you look at the wrong injection, overdose. Overdose probably has been, which I find the case is mostly by dental anesthesia, where really the calculation of maximum doses are not done. They just keep on giving. Empty oxygen cylinders, yes, probably when you are wanting to give oxygen, the backups are not there. Consent not taken, it is a specific consent for that procedure. Till now, I have not seen any case on awareness during anesthesia in India, but only 3 days back, I had a person who had an anal dilatation done. First time, that young man telling me that in that OT, I was awake. I knew I couldn't breathe. So the scolin was given with a little propofol thing and ventilating. And the first time, I saw the first hand without even asking. And he went on repeating this episode. Awareness is a common thing. And it does cause a lot of post-operative cognitive problems. And that's why it has a lot of compensations granted. Remember, it's a long-term problem. In spinal anesthesia given in spite of patient's apprehensions. Sometimes a junior person has planned a spinal. The senior anesthetist sees the patient in the preoperative area, convinces him for spinal, and something happens. So these are the cases where they have been implicated. Deviation from accepted practices was mostly cases like, the depomedrol, we used to give it so frequently in all our things, but ultimately moved on to the clearer solutions, triamcinolone and thing, than those, because there were certain pamphlets saying that this is not indicated. So you've got to respect those pamphlets. If you do it and something happens, probably we are putting ourselves in trouble. Ventilator not available, injuries and paresthesias. Intraoperative cardiac arrest, it is a very dreadful situation for all of us. If an arrest occurs and we revive and the patient is still hypoxic. Again, intraoperative cardiac arrest and hypoxia. Confident senior residents looking more at the surgical side than at the back of the machine, facing their back at the machines. Unnoticed disconnections. Again, it's a real incident I have seen. Though not seen, but reported, I know about around there in Delhi. The technician also thought, by the way, he just put it back when he noticed that there was disconnection. Patient ever woke up after an appendectomy and ultimately died of sepsis. So these things are real stories. They are preventable, and we know that preventable should be prevented by our vigilance. Again, for an elective cases, whenever we say, no, this is a hernia operation, patient had a certain myocardial changes or ECG changes just recently, please let us postpone it. It's an elective thing, it's not thing. Many surgeons will not listen to you. And the same was case in this case which has again happened in one of the hospitals in Delhi, where the patient had had an elective hernia surgery. Post-operatively, he had an intraoperative cardiac event and he did not recover. And they won this case because the wife and they said it was never told to us. Otherwise, we were not keen to get it if the surgeon would have said it or anesthetist would have done it. So remember, talk. Don't be afraid of the surgeons. Make them your team. Go together and at least voice this concern. Then this was lignocaine is again, where dental anesthesia overdose. Name was stuck by the General Dental Council. Now our medical councils have also started doing it. Especially I remember case where the violation of that MTP Act, where there was suspension of a name from the list. So this is happening now in India also. OT table. You have to look after your airway. And we have seen surgeons saying, I'm just going to take a small biopsy. Just do it under mask and I'll be fast. And when there are aspirations after that, remember, you have only yourself to save yourself. Nobody is going to. You are wrong. So those cases, after spinal, real cases, young person, ASA grade 1, a little obese, gives spinal and not prepared with the emergency medicines on your shelf. By the time they make those atropine and this mefentine, patient has had a cardiac arrest. And then this, okay, you can always say this was just an unanticipated thing. The patient is not transferred next door hospital or at the nearest hospital for this thing, taken to a faraway place in a person known to them in a nursing home. And this became, a big fault because what was the intention? Why did you take to that particular nursing home? So these small cases are also happening. Dr. Gopi Krishnan, I don't know. Can I see Dr. Gopi Krishnan here? No, he's here. I had a question from him. Post-spinal cardiac arrest, not able to revive the patient. How to prove that all possible interventions were done? Proof is only your documentation. Put it into documentation. Steps of what you have done, because which are the standard steps, how you will proceed. Put them properly. Don't overwrite and cut. If you need to overwrite and cut at that moment when you're in a hurry, cut it. Signatures, but that should be legible, because there have been cases when something was erased and put, then people call when in the courts those files were brought, people looked at it with the microscope and with the handwriting experts and tried to see what was written behind that. So remember, so you must write it. So would you like me to continue, or we would like to have something else? Because I have a few more slides. So, death after spinal, criminal liability. I think there's a case by now Supreme Court of India in August 2004. Previously, police used to, really take the anesthetist, seal the OTs immediately, and take it in a way as if the anesthetist is a criminal. Now, no longer that is done. They said they are not criminally liable. So, if the patient dies, they have to investigate differently. And post-mortem, there was another question of post-mortem, which will say that yes, in such cases, whenever the police complaint is filed, it is for the police people to decide whether they would like to get the post-mortem of that patient done. And they would also probably seize all the drugs that are there. So don't try to touch anything that is around it if it is death there and there has been violence and people have literally barged into the thing. Let the things lie there. There are times when the police has seized the documents even when the anesthetist is writing. Let them do that. Keep a record of yourself, whatever you have mentally think to yourself, that and you can write that they were seized from it. So there are benefits of good documentation. Keep it up, because the case may come anytime after 2 years or 3 years, you will not know. Because there's a limitation period. In civil courts, 2 years, in some courts, 3 years. So you've got to keep your documents safe. When in 1954, people didn't know that we could sterilize the ampules, how to do it and all. They used to do it in phenol. And this was one of the oldest cases where two patients had the paralysis from waist downwards. But they were not held guilty, because at that time, how to sterilize it or not was not known. It came only later. So these people were not held guilty. They were not penalized. Defibrillator not payable, death on table, what to do? We must all, whenever anything happens, call for help. Your own seniors, colleagues, everybody. Inform the administration. Police, whenever anything happened earlier, the coroner's courts used to come and play now, I think only in Hyderabad and Calcutta. Those are the only two places where there are still some corner scores. But here the police does take over when somebody informs them, especially when the relatives go at it. Leave the OT disturbed, complete documents, photocopy if you can, and ask for post-mortem from the police that we would like to know the cause of death if you are not. Aspiration of gastric contents is the commonest thing, but if it is due to patient's obesity or absence of teeth, the anesthetist, and they have well prepared the patient, they are not held negligent. But there's another case where an elective surgery is done, patient aspirates during extubation, and in such cases there have been the courts have said both are guilty, probably they didn't prepare well. So there are different types for the same situation, there's different types of judgments depending on those things, and they also quote certain judgments which were like this. So that's how the courts work, because here in the third case where the silent regurgitation occurred, who had a parotid surgery and there was brain damage and vegetativeness, the hospital authority was held vicarious liability, and they says, look, this res ipsa loquitur, this thing speaks for itself, was applied, and complainant was given the compensations. It is just to pacify them and say, okay, they suffered a damage. That is the main thing. Blood not available, I've already told you. Again, it not being available, almost 2,35,000 at that time. Now I know the latest is 6 crore for that person who lost his wife because of that misprescription of the steroids given in high dose to treat lupus or something. So the damages are going high. There are some people, when you have a protocol, you follow the protocol, they are not held guilty. This is how it goes. Again, I said without endotracheal tube, biopsy of growth, don't attempt it, because if something happens, you are liable to be held guilty. Verbal consent, there were times, yes, this question came somewhere in India itself, and there was a thyroidectomy in an elderly lady who suffered from a CVA postoperatively, and they said that ultimately the allegation was consent was not taken. So they will argue only the thing which is an allegation. They will not look at other things. There were no notes to say that the consent was taken. But they presumed, because there was a referral letter from another physician to that surgeon, so he had the copy of that referral letter. And since the patient was there in the hospital waiting in the preoperative area, they had arranged for blood, all those circumstantial evidences, yes, they knew that the case was going to be done. So the verbal consent that was said, it was enough in that case. So they also look at the magistrates and the judges, they look at certain things. Informed consent of anesthesia, we must know how much to tell. I think in the present day, even we have started telling, we are videographing, if a renal counseling and all that, we have started even audio, video, everything, just to protect ourselves. Probably that is going to happen more and more when people can just say, no, we were not told. Documentation, you have to do it. Don't try to make too big consent forms. They should be specific. They should be placed to write what this patient specifically suffers from. What are the alerts of that specific patient? So there has to be place for everything to write that, and even the risk. Avoid documentation pitfalls. Everybody, especially in surgery, I see that half the people will go and start writing the notes. So avoid that, because again, their entries time may be different. Conflicting times. Don't sign inaccurate documents without reading them. Document each meeting with the patient and the family. Even what I try to do is, when during the PAC, when I find 3-4 people aside, I explain the consent form them. I take the signatures of all of them with a mobile number of 1 or 2. So that way, and I tell them to write it in their own words. So that and document it. That's very important. Burden of proof, normally in law, the burden of proof, if something happens in the wards and all, it is on the complainant to prove that something has gone wrong. But when it happens inside the premises of the OT, where the relatives have no access, the burden falls on the doctors to prove what went wrong. So remember, it is just shifting from the complainant to the doctors. So you have to be more meticulous in keeping that as a proof. You have to define your own standard of skill and care. And law does recognize that medical treatment is full of risk and the desired outcome may not be reached. Again, I have already talked about 2 techniques of anesthesia. That is the bolum thing. And now it has come to bolitho. Legal pitfalls we all know. When we abandon the care, when we don't go, when we are called for the cases, we try to only give instructions on telephone. Because again, a case in Delhi where after a cesarean, patient had back pain done under spinal. The anesthetist says, Voveron laga do, yeah, something myospasm de do. Just a verbal thing, informal to the gynecologist saying, this is still an ongoing case because he just gave it, he didn't come and see the patient. And patient complained that that person who prescribed that did not come. And some problem she had after that, so just because of that myospasm. So legal pitfalls, I think I have already done. What to do? Do not alter any records. If you have to do it, write it fresh, and you could put a date. Reply to the notice from court with the help of a lawyer. Take the help of the experts in your field so that they can help you frame those replies. Inform the insurance company. Seek help from the legal cells of your own associations and societies. Seek expert opinion from seniors, and try to keep a tab on the progress of the case. Attend all the court happenings that have happened, because sometimes the advocates that you have, they really don't have any knowledge and are not able to defend you. I've seen people getting up and the anesthetist saying, I'll defend my own case. So remember, such things also happen. So prepare your defense, look at the internet, look at all the things, collect all the favorably decided court case, as well as in your medical literature. Like recently there was cardiac arrest and intracardiac injection was given. The expert committee from a government hospital said that is not the way that we do it now. Nobody gives. But that she was in a small setup, in a where after tonsillectomy near cardiac arrest occurred. They gave it immediately, patient revived and all that. So even this had to be disputed. So you have to show the medical literature. And nobody they have said that it is banned. There may be something. So we have to collect which is favorable to our doings. There have been favorable observations. Don't conceal this is concealment of information by patient questions or by Dr. Naveen Agarwal and Dr. Murli. If patient didn't reveal his dental fillings pre-operative and post-operative, they found it missing. Again, I would say that we also have adapted certain pre-PAC checklist, which is filled and signed by the patient relative, and they're dated. We use it as a preliminary to our pre-anesthetic checkup conversation, because we try to, sometimes when we say, do you have any cardiac disease, they write no. And when we ask them, yes, they have high blood pressure, they are taking medicine. So we do modify it on the side of it and signate it. They have written no, we have written yes. So they are conflicting, but we try to do it at the same sitting. So this particular checklist is a thing which is a solution to it, filled and signed by the relatives with the time and date. And I discovered this checklist when I was with one of my own friends in a nursing home, where there was a consent form. At the back of this was an information checklist. I was really lured to it, and I adapted it in my hospital. Second, if a patient doesn't reveal history of URI antiplatelet therapy, again, it will probably reveal in your checklist. Put those things which you think that the people are tending to not reveal. Put them that do you take any drugs like antiplatelet, with naming certain drugs. Would the court accept what we write if the patient makes a U-turn in the road? I think the written documentation is only your savior. And you would, and somebody did suggest that you could write that patient denies significant medical illnesses, but I would add it such as. So if you think such as, so that will probably confirm that you did ask for an antiplatelet drug, URI and all. Put those also in that. Don't try, because don't make it thing which is liable to be questioned. That I would say. So who is responsible for anticoagulation part of the patient? Dr. Naveen Agarwal asked this thing. When I looked at it, even in my own hospital, it is. I find many surgeons like to give preoperative, orthopedic surgeon also one day before. Some don't like to give it. As anesthetist, we don't interfere. In the first one, we interfere only when an epidural is there and they have started an oral anticoagulant without asking us. Those checklists and everything we have put on the notice boards of our retiring rooms also, because we found we couldn't remove that. I think these new oral drugs they have started using before our epidural out, we were not doing it. When I looked at the literature, I found that it is a good system to constitute an in-hospital pharmacist-led multidisciplinary anticoagulation management services with physician, surgeon and cardiologist. Anesthetist's name is not there. If you want to be involved, go ahead. Why not? We are always, I think in every committee of the hospital we are members, so why not in this? Because the epidurals do affect us. And I remember in one of the big hospitals, this heparin after a vascular surgery was given, epidural was inserted, and the epidural came out accidentally. There was an epidural hematoma, and they started on even anticoagulants before the epidural catheter. I think this was presented in one of our meetings. And they said that we must note down whenever an epidural is there, also put down that patient may have a chance, look for sensory loss, look for these things should come as a precautionary advices from the anesthetist. Medical legal aspects to own an ultrasound machine as a freelancer for regional intervention. This was a question from Dr. Sunny Basin. Remember, there's a PNDT Act and it has been amended recently in 2003 and then in 2013. All ultrasound machines have to be registered under this law. Even the manufacturers are required to furnish information about practitioner, clinics to whom ultrasound machine has been sold. This is a manufacturer duty also. It is mandatory to maintain proper records of use of ultrasound machine which is capable of sex determination. For every scan, every record has to be kept. You have to display at the place where you are doing ultrasound, whether it's a portable one, then the display on that van, you'll have to display that sex determination is banned and it is illegal. There's to be declaration on each report that ultrasound neither detected or disclosed the fetus sex to anybody, and the pregnant lady has to certify she doesn't want to know sex. Then there are a lot of supervising bodies which have been constituted under these amendments, which is Preconception Prenatal Diagnostic Techniques Act, which are monitored by the central and state level supervisory boards and implemented by multi-member state authorities. And remember, this is a cognizable offense. It is police case. The person can be, doctor can be arrested without warrant, and it is non-valuable. I think I wanted to write non-valuable. It is non-compoundable. No out-of-court settlement can be done. So they are very strict about it. With the declining female ratio, it is a strict, it's an issue of concern for the governments with sex ratios being screwed like anything. In Haryana, in everywhere. So it is going to be stricter, and there are monitoring deputy commissioners. I know my classmate was deputy commissioner, was supposed to monitor, and that's how things are going bad to worse, but I think doctors must be aware of it. Then this was Dr. Sunil Gupta, who said morbidity and mortality due to accidental extubation in ICUs. They happen when the patient fight with the ventilators and there is no monitoring. And especially I say at 3 o'clock in the morning, at 4 o'clock at the worst time, when half asleep, the doctor is in his duty room, the nurses are half asleep. Who is going to be responsible? Now, whether it's the consultant in charge, I won't say, because consultant in charge, unless he has been called for it, think he has to come. That's definitely his duty. If it doesn't, then it's dereliction of duty. But the person who was there, on whom, like a senior resident, has to be answerable. The nurse has to be answerable. But since they are not independent in charge of the patient, this has happened, it's the hospital vicarious liability, and some action will definitely be taken. And on the behalf, suppose they say that negligence of these two, and they are on salaries, this is the hospital which will bear the vicarious liability of whatever it may be. That is how it goes. Then orthopedic surgery, we all know, awkward positions. Long surgery, 6 hours, they'll say 2 hours, it will go on, and we have no control under the drapes at all to re-examine. The courts, when they have given judgments, though it's a surgeon's responsibility to do it, and while they are doing it, it is anesthetist's responsibility to see that all points are well padded, because ultimately when it comes, their maximum compensations are asked, because they all know there are insurances for everybody. Everybody may be carrying, so crores, they will ask. So remember, you have a responsibility of looking at those points. There have been cases of post-operative blindness, corneal abrasions. We are anyways doing it. Corneal abrasions say you didn't put in the saline, you didn't pad it well, so anesthetist gets blamed. There was a case where anesthetist, where it happened as post-operative blindness after an orthopedic surgery because of that insufficient blood supply to the optic artery. But luckily it happened in one of the prestigious hospitals. This case did go to the court. But because, they had taken all the measures, they investigated when they found it, and after that, whatever the residual was there, they couldn't do anything about it. But since the patient was properly managed, and this was not an expected thing, and they did give us the learnings after they presented it one of the fora, that how you could put a little head up and all that to prevent things. So those standards now, I think we should all take all those things and start applying and put it in our documented, like we all have our SOPs, put them in our own SOPs to say that we follow this. These will help us in long term. Who is responsible for postmortem? I already said postmortem in India. Normally, we don't have those academic institutions where we are allowed to do our own postmortems. There are, I think, in other the people who are from abroad who have worked there, they know that they would do it for the learning also, that what went wrong, whether there was some poisoning or there was an overdose, they will do it. But here, yes, it is an individual base. If it's a police case, the police decides. Still, I have not seen that doctors have been saying that we want a postmortem in this case. And whether police will comply, I am not sure still, because I have not heard of any such case. But I'm sure it's time that when we feel that we would like to know the cause, instead of them doing it, if your hospital administration agrees and all, you could ask the help of police and they would take to the government hospital. It's only government hospitals who are authorized to do postmortem in such cases. So, but onus is on the doctors to treat and try to save a life, whatever happens, whether it's an embolism or anything. And again, the steps of your management should be what the standard of care says from the guidelines. Right now, there's a blurred thing. We are following everything American, and I'm sure many people don't even have those facilities. So that's why I'm saying your own things, own setups. If this happens, whether you will transfer a case if you don't have facilities to do this, put it on the paper, on your SOP, because and which cases you will like to transfer your case to a tertiary care. All these things should be part of your SOP. Please do go and make those SOPs for yourself. Then, if registered with MCI or DMC as anesthetist, does he need to register in Haryana Medical Council again to do the practice there? This is from Dr. Vineet Gupta. Yes, the answer is yes, because we feel why we should be registering to all the, so everybody they take a little money and they do it. It is a section 22 of the Indian Medical Council Act that I found. It was last amended in 2001, which is that there is need to supply of copies of the state medical registers to the MCI. Each state medical council shall supply to the council 6 printed copies of the state medical register as soon as may be after the commencement of this act and after the first day of April of each year. And each registrar of state medical council shall inform the council without delay of all additions to and other amendments in the state medical register made from time to time. So according to this, it appears, yes, it is necessary. So go ahead with it. You will have to shell out another 1,000 rupees or something. Don't shirk from it. That is their duty and we should also do it. Take preventive measures, I would say. Keep your monitors. Keep up to date. Improve your equipment. Maintain your existing equipment. And in equipment, do have that sticker of preventive maintenance done on watch date. Please do that because these are the things which are looked into, whether you were maintaining them. Improve your arrangement of drugs and equipment so that there is not sometimes atracurium and adrenaline may be lying sideways and in a hurry you do that. Better training, supervision, more personnel, more discipline. Keep your checklist. I think in every OT there should be one checklist hanging because you can't keep everything in the brain. At that time you will forget one step or another. There may be some person who may tell you haven't done it, do that. So probably we'll need to do that and certain algorithms and guidelines are already there. And better quality assurance. Thank you. Sorry I took so much of time. But
Sorry. There will be, I am requesting ma'am to be on the Facebook, join our group. All questions, I know she will be the maximum, she will be getting the maximum post. So please ma'am, please join Facebook, please join our group. Because when I requested her, she said I am not using Facebook.
No, I am using Facebook, but I don't get time to do it. I'm actually overly busy till now. Yeah. But I will definitely try to answer. Make them as you did this time. on, just if you could, in the meantime, because, main being working full time and doing so many responsibilities, I'm not able to go regularly. So I won't promise, but my personal email, if you can just compile it, I will reply to each one of you, because that is what I like to do. But Facebook also, at WhatsApp I saw, I could probably do that sometimes. Yes. It's easier.
Thank you, ma'am.
Thank you, ma'am, so much. So we go for a group photograph right here, right now, for a simple reason that people have flights to catch, and I know they will be just wanting to leave. So sorry, sir, no questions here. I know madam will be mobbed outside for lunch. So please come here. We will have a group photograph in all our t-shirts, please. Most welcome. Yeah, thanks.